Good morning. The topic today is transitioning from adolescent to adult health care. My name is Allyson Bolduc. I'm a physician, past president of the Vermont Academy of Family Physicians, and on the board currently of the Vermont Academy of Family Physicians.
Good morning, and I'm Jill Rinehart. I'm a pediatrician in Burlington with Hagan, Rinehart Connolly Pediatrics and the current president of the Vermont Academy of Pediatrics.
We are having some technical difficulties, but now we're online. So today's objectives, we are going to be talking, as we said, about transitions, what they are, why does a smooth transition matter, some of the national priorities about transitions, some local projects, both here in Chittenden County and elsewhere, 5 steps to a good transition, and then we'll wrap up with a conclusion. At the end of this, there will be a number of resources and also worksheets, and they will be on the webinar at the end. What are transitions? There are many transitions that we have in life. It is technically the process of changing from one state or condition to another, but we know that a transition is from when you're crawling to when you're walking, from when you start kindergarten to going to middle school, when you go from work to continuing education while you're working, from school to work. Even relationships have transitions in them, from peers to bosses and teachers, going from home to an apartment to group living. All of these are transitions, and they don't happen overnight. They take place over a long period of time as we are ready for the next step in that transition.
This is a theme that we use a lot when we talk about adolescent health. And the Circle of Courage is something that talks about a developmental approach to moving through the life course. These are the things that we feel are really important for an adolescent transitioning to the adult world. This has been introduced to our community through Dr. Paula Duncan, and over the years has been a backbone of how we help prepare adolescents for adult life. So finding capacity for independence, a sense of belonging to community, having a feeling of mastery that you're getting better and better at something, and then kindness. Adolescents do well by giving back to their community. We'll keep these things in mind as we think about transition.
So the key factors in any transition are a need for planning. You need to know what you're going to do going forward, taking small steps over time, increasing responsibility of the patient when possible, and then increasing independence, as we've mentioned. Why does it matter? Well, because as we plan, we can then look to what we need to plan in the future. We can maximize our education that we have going forward. For instance, if you're looking to go to a technical school, you'll be able to take those classes in high school or in middle school that will lead you toward that. Same thing if you're interested in going to college, you need to work on starting that process of what education you need to have, what courses you need to have to move to the next level. Coming up with a work plan. What do you want to do? Where do you want to work? How would that work? Maximizing your health without interruption. Sometimes transitioning from one practice to another takes a little bit of planning so that there is no interruption in your health care. No gaps in health insurance. No gaps in ongoing health care with a new provider.
So what do we know about adolescent health in Vermont and this transition population? We definitely know that ages 18 to 26 are a high-risk health population to begin with, at risk for falling through the gap, essentially, of losing their medical home. In Vermont, our school nurses survey tells us that well visits are really good early on in school, with high percentages, up to 80% of kindergarten, and then they decrease down to about half that by senior year in high school. There are 24,000 adolescents right now, currently, in 9 through 12 in Vermont. And our Bright Futures Pediatric Guidelines recommends annual well visits through age 21 every year. there are, in times of major transitions, they're often problematic, as Dr. Bolduc said, moving from school to work or work to school and leaving home, new environments, all of these things can provide a difficult source of continuity for the medical home during this adolescent time. Specifically, what are the challenges to our Vermont transition system? And I did put that in quotations because we haven't really got one yet, but we're working on it, and that's part of today's work today. So initially, as we said, Bright Futures does recommend annual well visits from birth, actually from 3 through 21, and then more frequently under the age of 3. Currently here in Vermont, if you're 14 and over, that's considered an adult age for pediatric surgery in many cases. For age 18, that's an adult intensive care unit visit and not in the pediatric intensive care. 18 is an adult for psychiatry as well as for many of the adult subspecialties. The Affordable Care Act allows for a youth to remain on their parents' policies through age 25, and individualized education plans are effective for those with disabilities through age 21, so to age 22 actually. Other complications that happen in this population, pregnancy, parenthood. If my patient becomes a parent, they, male or female, are typically moved to Dr. Bolduc's practice or an adult practice. An emancipated 16-year-old has its own set of issues, and then guardianship as well.
So we're next talking about national priorities. So it's sometimes easy to think that this is happening just here in Vermont, and in fact there really have become some national priorities in the transition issues because it occurs throughout the country. Title V agencies represent every region of the country, and of the 2015 block grants that were given to states, 32 states selected healthcare transition as a priority, which is astonishing and really the first time that that's happened. So we're moving forward with that transition, and everybody's looking at it throughout the country. There are 24 of the 32 that focus on youth with special needs, not just transition in general. So there was a clinical report done in 2002, which was a consensus statement on healthcare transitions. And then in 2011, there was a joint statement by the American Academy of Pediatricians, the American Academy of Family Practice Physicians, the American College of Physicians, which includes intensivists or intensive care physicians, as well as specialists. And what they did is they said that this is really important, that we need to transition and we need to plan for that. Dr. Matt Holder, who was just here in Vermont, has been developing a model, a medicine model for developmental disabilities. There are also, again, in Tennessee, in Massachusetts, in South Carolina, in Denver, Texas. Again, we've seen these transitions and work with intellectually and developmentally disabled adults, local champions for that. In fact, there's some work done to begin family medicine department clinics for folks. And in fact, for the very first time ever in September, there will be a transition issue training with the American Academy of Family Physicians at their annual meeting.
So we've defined sort of the problem here, and what we're looking at now is how to bridge the gap with transition from adolescent health to adult health care. And I believe it begins with these steps that we're doing right now. So, and there's policy support for transition as well. In 2011, again, we had a combined academy policy statement supporting the healthcare transition from adolescent to adulthood that really prioritizes it for all of our medical groups. As recently as in 2014, Pediatrics published a transition of care for children with special health care needs set of guidelines. And yeah, and ultimately, optimal health care, and this comes from the policy statement, is achieved when each person at every age receives medically and developmentally appropriate care. I think that's key, the developmentally appropriate. The goal of a planned healthcare transition is to maximize lifelong functioning and well-being for all youth, including those who have special health care needs and those who do not. And I'm a believer firmly that if we make a system of care that works for the most complex, then the more typical should be a smooth transition as well. within Vermont locally, this is a real priority as well. Currently, as part of our accountable care organizations, increasing adolescent well visits, which I believe are really focused on building those characteristics of independence and mastery and preparing children for transition, is a measure for our affordable care organizations. The Vermont Medical Society has a resolution. Our chapter definitely has a priority. We do have a toolkit, and Got Transition, Center for Healthcare Transition, is a big resource that we use throughout this. And currently there is an interdisciplinary group working with adults with special healthcare needs at UVMMC to work on a system of coordinating care for medically complex youth as they transition to adult care. We'll be talking a little bit more about our own local pilot on transition that Dr. Bolduc and I are doing.
As a side note, the Vermont Family Network has a wonderful toolkit which are planning tips for transition-age youth and their families, and I encourage you to look at that. It is online, but if you have trouble with that, I know you can access it at the office of the Vermont Family Network. There is a yearly guide of what to consider, you know, the individualized education programs, the personalized learning plan, the timelines. And again, remembering that planning may begin in middle school. You can find that at vermontfamilynetwork.org. There's also a letter that some folks receive from the State of Vermont Department of Health and Children with Special Health Care Needs, and they're reaching out at age 17 about transitions.
So this is a recommended healthcare transition timeline that can be found through the Got Transition website. Specifically, age 12, thinking about this with youth and family, that they're aware of a transition policy. So the idea from a pediatric perspective, whether it's a family medicine office or a pediatric practice, that your youth will be taking on a different role as the child ages to adulthood. By age 16, preparing both the youth and the parents for that adult model of healthcare where the patient is the center. And ultimately by age 18 to 22 being able to transfer the adult to an adult medical home and with specialists as well, so that it's a smooth and warm handoff. That's our big goal. Sometimes as a pediatrician, and I think as families too, it feels a little bit like you're going into the void, leaving a pediatric focused practice. But ultimately what we want is for that not to mean that you're losing your family centeredness. But it has to continue, the relationship has to continue to be proactive with timely and accurate problem solving communication. And I think when we work with families, that's something that we fear losing the most. And a relationship between the young adult and the practice does change over time. And I think challenges for families as they share their experiences with us is that the system of care seems to change. So how can we prepare families for that as well? I do believe the patient-centered medical home does support care coordination and the model that we are transitioning patients are used to. And this is an example, thank you to Tammy, who recently put together, this is called an eco map of her child. And when you think about all the places that the medical home and the family interacts with to support a child with special health care needs, I think it can be daunting thinking about transitioning all of that to a different medical home site. Next slide. The other thing to consider is what happens when we include the voice of youth with in the transition process. This is a recent article from the Washington Post that talks about the voices of adult self-advocates often differs from their own parents. So whereas parent advocates of children with chronic conditions have always and long worked toward cures, the adult advocates are really shifting the focus of work towards independence and independent living and work.
So now that you have the background a little bit about this and the real importance of this, there are 5 steps to a good transition in healthcare that we've identified and have been identified through Got Transitions and other people working in this area. The first one is discovery, and we'll go through all of these. The first one is discovery, next is tracking, then preparing, then planning, and then actually transferring. So step 1, discovery. What does that mean? Well, we need to know what the healthcare professional's approach to transition is. You need to know why there's a need to change medical homes. Do I even need to change medical homes? If you're in a pediatric practice, you do need to change because they do have usually a policy that says either at 18 or 21 or 22 that they do want you to change to someone who does more with adult care. If you're in an adult practice, relationship changes. If you're in family medicine, you can probably stay with them, but again, the relationship changes a bit as you gain more independence in your own health care. The pediatric practice policy on transition age, every practice office should have a policy on transition, and they should be talking with you about that either by posters or letters or even in person.
I've included this letter that has been made available for our Vermont Childhood Improvement Program on adolescent well visits, specifically about why and how to support an adolescent to be ready for transitions.
So we're having a little bit of technical difficulty again. But what can you do to help in transition? So the adolescent and also the parent can try to help, as well as physicians and our office practices can try to really help to be more ready, to be more independent, to take more responsibility as people are ready to take more responsibility, ready to be the primary patient instead of the adult or the guardian or the parent taking the role, shifting that over to the adolescent. We need to spend part of each visit alone with the primary care physician. Again, just to talk about those things that are important and to develop that sense of being the primary patient and taking that responsibility. You need to find out about your rights to privacy and confidentiality that changes as time goes on. And does the practice have a written policy that helps with transition?
A big assumption, though, that I think it's hard for families and parents sometimes to make is that we assume that these families and children are ready for independence. This is a photo of my younger brother who was in high school with medical complexity, intellectual disability, and some significant behavioral concerns, and he lives independently now with support in the community, but it took we had to really believe that he could do it, and he definitely wanted to do it in order for transition to occur.
So step 2, tracking. So this is again something that can and should be done as time goes on. And again, you can start this early, or the parent or guardian can start this, and then later that can be shifted to the adolescent. But that's keeping track of your healthcare information, having a calendar for appointments and writing those in, making sure that you get a printed copy of the medical summary. That includes allergies, a problem list, medications, support people, all of those things that are really important, an emergency care plan. And then a shared plan of care is really important as well. And there is a template that's achieving a shared plan of care with children and youth with special health needs. But this should include at least a medical summary, an emergency care plan, an eco-map, family strengths and goals, and next steps. And what to bring to appointments. Again, a list of your medications, scheduling the next visit, taking the prescriptions for your medications, bring a list of what you need and when they are about to expire. How do I call in to get a refill on my prescription? Making sure that you have your insurance card with you. And above all, understanding the instructions, and if you don't, ask questions and make sure that it's very clear to you, or you have somebody with you that can help to explain those after you leave the office. But never be afraid to ask questions if you don't understand. It's so important because the people who are taking care of you need to know what you're thinking and what your questions are, because we want to make sure you're as well informed as can be. There is a wonderful book that I would recommend. It's called Being a Healthy Adult, How to Advocate for Your Health and Health Care. And this is really, it's a free book, and it has some wonderful tools in it that would be really suggested reading for both the adolescent as well as any parent or caregiver in their lives. There is a support workshop example about writing things down, what you feel you can do, where you need to ask for help. There's also a worksheet that one can do, the problem that needs to be solved, and then going through how you would solve that. List of things that need to be done, things you could do yourself, things that you need help with, and who or what will be able to help me get this done. Again, this is not something that you can start doing all of a sudden just by yourself, but it is something that can be done over time as you develop more independence. The other one is how do I get the doctor's phone number? Write down any questions before I call the physician or the office. How do I do that? So again, these are things that one prepares for at the visit. Step 3 is preparing. So again, we just talked about that a little bit with those support tools that we were talking about and just showed you. When do I need to start thinking about transition? It takes time to practice and gain independence. You need to plan with the IEP in school, and hopefully you will get that as you move forward. And if you're traveling independently with a team or school program, you need to have an insurance card with you, know medications, or take a list, and any contact numbers that you have.
So ultimately, we're transitioning to become more in charge of your own health care. Establishing that first appointment and first prescription refill, it really essentially creates the relationship with the medical home. Asking questions so that you are certain that you're understood, and any pre-assessment that we can offer that establishes how ready the young adult is for the transition. And as we talk about our model that we're piloting, preparing and seeing where the young adult is in their transition process is a big piece of that. As a parent, how can I let go and I think ultimately it's one step at a time and giving the process a chance, but starting early is really helpful. Ultimately, for both physicians, families, and young adults, I think assuming competency, assuming that this can actually come through to fruition. I speak for myself. As we move towards this age group, it can be a little daunting as a physician, and I now am really working towards assuming that there's a competent transition process that's supportable.
So step 4, planning. So again, as we've tried to say throughout this, that the planning should start early. At age 12 and 14, 16, 18, during all of this time, the planning should begin. At age 18, there are legal changes that occur. Parents no longer automatically have legal control. The 18-year-olds can consent to their own medical treatment. And so if you want parents and guardians to have permission to talk with the primary care physician and the office and to involve others in your medical information, written permission needs to be obtained. Who makes the medical decisions? That has to be decided. If your young adult needs help with medical decisions, there are options. You may need legal paperwork to continue to act as guardian. File paperwork to be the guardian, medical advocate. Have to have that legally on record, and you need a signed consent at the doctor's office.
Transitioning to an adult medical home, how do you find an adult doctor, finding a new doctor if you're in a pediatric practice? Currently, I think starting with your own office, many of us have lists and should and may suggest and help with that transition. Talk with people that you know and who they liked as their physician. Other parents, teachers, therapists, local agencies in the community may have relationships they've already groomed with adult medical homes. There are healthcare plan directories. Certainly calling the office itself and asking about what insurance they take, if there's a hospital affiliation, and if they care for other adults with similar health issues. And it all takes time. And after the first visit, you can decide if it feels like a good fit or not. At school, so in our practice, many youth will stay in our medical home through the college years, so that's where that 22 comes in. However, if you're taking a diagnosis with you to college, having an updated shared plan of care is really essential. And the young adult needs to be their own advocate. And that may mean starting with the Disability Services Center at the college campus, explaining what special supports or needs that they have to teachers. It's really important to have accommodations in place before arriving on campus if they are needed. We still maintain annual well visits for those adolescents, young adults that are leaving our community. They come back often in the summertime. If there is a chronic condition management visit, like asthma or ADHD or for special needs, we may work that out as a visit when they come home at the holidays or at the winter break, etc.
The other thing that needs to be said before we talk about transferring is that, as with everything, we can't do this alone. The physicians can't do it alone. They need the help of the young adult. And the young adults very often can't do it alone either. We all, it takes a village, as they say. And so when we have important people in our lives, and they remain in our lives for a long time, and so sometimes that can be really helpful for the young adolescent or young adult in managing their medications. Sometimes the medications don't seem to be working, and the people around them have a really good sense of how that's going, and we need to encourage that input in going forward in their medical care. So I encourage parents or guardians to establish a relationship with their young adult and adolescent, and together, even though we're talking about independence, and we're really talking about independence in the sense of really relying on those people as well to help in the care of their child.
And communication can be specifically defined so that if that young adult is concerned about maintaining independence, but they also know that it's important for community providers and parents and family to have information sharing, they can limit it to what they feel comfortable with.
So the next part is transferring care. So what actually goes into the transferring? What information does my current doctor need to send to my new doctor? So the current doctor has been with the young adult, usually for many years, as have the whole family. And so it's really important that that information that's gleaned over that time is sent to the new physician in a shared plan of care, perhaps, that everybody sits down and talks with at the current physician office. And a copy of the medical record, a summary of any recommended treatment should also be sent to the new physician. Perhaps a call from the pediatrician to the new physician would be helpful as well, or someone in their office, perhaps a care coordinator, who can make that transition a warm handoff. It should include a letter of introduction, and would a condition fact sheet help? In other words, the new physician may not be as familiar with the condition that the young adult has, and so a fact sheet may be helpful to be sent along with it. And then the young adult should check to see if the new office has received the records. It's also important to know that adult care is different from pediatric care. The main difference is that you are usually the only one communicating with the new doctor office unless a release is signed. And again, that's really helpful to have everybody on the same page with that. Adult approach should take place at both the old and the new office. Again, this is something that in the transition process occurs over time. So again, it's not something that happens one day and all of a sudden you're in a whole new situation. As you transfer again to the adult provider, you're expected to manage your own appointments, medications, payments, insurance, refills on prescriptions. But again, you don't need to do this alone. This is done with help, and again takes time to occur. Some of the questions that you could ask: how to make and change appointments. If you haven't ever had to do that before, maybe you're starting to do that in the pediatric office. Is there transportation available, parking? Is there wheelchair access at this new office? When do you need to arrive? What to bring with you? What services are available at the new office? Are there care coordinators? Is there social work available? After your first visit, give feedback on how well it went. What could help you more, because the offices will really be looking for that information so they can best keep you at the center of the patient care. We're going to jump now to a local project, the pediatric to adult medical home transition. Dr. Rinehart and myself, along with Dr. Frankowski, were at a couple of meetings together with the Vermont AVCHIP, as well as a primary care public health integration committee. And we were talking about the role of transition and how difficult it seemed to be to make that transfer happen and happen well. So we decided we would put together a local pilot project to see if we can improve on the system, or even put together a system that, that encouraged that good transition. We knew that adolescents, young adults were a vulnerable population, as we talked about. It was a high-risk group likely to drop out of the healthcare system when the help was most needed. So we needed to set up some goals.
Yeah, and ultimately for transition process, we're hoping for a warm handoff that is seamless and welcoming for all the young adults. So we defined a population of one single chronic condition, such as asthma, ADHD, or anxiety and depression. And we have, from both my practice and Dr. Frankowski's, transitions to 4 adult medical homes. The pilot includes a pre-assessment for readiness. That's not a test that the youth has to take in order to be accepted. It just establishes where they are in their ability to understand and manage their own care. We do use the Lucille Packard guidelines for achieving a shared plan of care as our template and our guideline for the information that we want to share with the adult practices as they transition. We've identified in our practices an office champion. That's often what it takes. As we talk with our colleagues in the as physicians, it's really not even a barrier for the physicians to take on this population. It's often the system of communication between offices. So we looked very closely at how to have an office champion there. And then ultimately figuring out a way to track this population so that we can have a post-visit assessment afterwards, after the warm handoff has happened.
So again, the transition period is a formidable time for a young adult, in that they have to do some things for themselves that they have never had to do before. Again, this is something that we've talked about throughout this whole webinar. It is something that we develop slowly over time. In conclusion, we want to say again that planning is a key. It takes everybody involved to make sure that this works well. It takes time and energy to make a good transition, and it's worth the time and energy going forward. The transition process begins earlier than one would think and progresses slowly. So again, the transition process occurs as people again develop more independence and as they're gaining more understanding of themselves, and again takes time over a number of years really. The provider community and many other groups and agencies are working hard to make transitions possible and easier. I know many people have had a very difficult time finding an adult provider to make the transition to. I know it's hard for parents and young adults to move from a medical home that has been welcoming and warm and has been a long time in developing trust and coordination, and it's hard to move, as with any transition, to the next step. So we're working hard to make that easier for people. We do also know that more provider training is needed along with more accessibility. We need to make sure that providers understand the transition process, that they're ready for that they are skilled in taking care of the young adults, regardless of their background and needs and healthcare needs.
And to conclude, one comment too, transition does look different for different subpopulations of this age group, and there are efforts going on currently to help transition for young adults with chronic conditions as they age into adulthood, such as cystic fibrosis and diabetes, or chronic kidney disease. And so there is a transition that can occur both with the subspecialty level of care as well as the primary care medical home, and both are necessary as we transition through this process.
As we said, there are a number of resources that are available to help with this. Gut Transition is a good one. Vermont Family Network that we talked about. Again, we do know there's a clinical report that is talking about this. There are national priorities now as well as local priorities. There are many tools as well that can help, and again, we will have some in this packet as you look through it. My Health Passport was developed in Florida, actually, and they have put together really a very nice sheet, several sheets actually, on who you are and what you need for your medical care. So again, some sample medical summary and emergency care plans, some transition readiness, checklist for healthcare transition, 10 steps for successful healthcare transition, and a sample plan of care. And again, this is the My Health Passport that was developed in Florida. And as you can see, it's bright, it's fun, but it's also really helpful. And again, one of these may be really helpful to bring into your new physician, and it can even be filled out by you and your current physician before the transition takes place. But it really is helpful to even take wherever you are if you end up needing to go to the emergency room, or if you're going to a subspecialist or a primary care physician. My favorite foods and drinks are, it just helps the physicians get an idea of who you are and what your likes and dislikes are. This is a sample transition readiness assessment for youth that we have been doing with our pilot project, and this just assessing how people assess their own needs and how they feel about whether or not they can take on this new responsibility. This is a healthcare transition checklist. The one previously was actually a readiness assessment for parents, and that's actually sometimes very good as well, just to say how ready are you for your young adult to move on to another medical home. Healthcare transition checklist, again, at each age, it just shows what you need to be thinking about. This is a sheet about pediatric versus adult care and how they differ, and again, this doesn't hold for every subspecialty. This one has to do with PKU, which is a specific illness that starts as a baby, really, and continues through adulthood. But the second one is parents are in charge, and then the care is self-directed in the adult care, again, with help. This is just a sample transfer letter from the adult provider to the new provider, just giving a little bit of background. This is a transition policy letter that can be used in the pediatric practice. 10 steps to successful healthcare transition. Again, as we've said all through this, start early, focus on responsibility, create a health summary, maintain wellness. If you have an IEP or an individualized education plan, We are working hard with the state nurses to talk to them about the possibility of sending that IEP home when people are done in the school that they're going to, so that they can have that as a part of their medical records and educational records for a future. Find adult providers, know about legal rights and responsibilities. And then this is a sample plan of care, again, that one could take into a physician's office if you wish, if you're not sure that they have one. This is a sample medical summary and emergency care plan that can be filled out with both the provider and the parents and the young adult. It's several pages long, and again, it's several pages long, and again includes everything from allergies to what schools that you've gone to, and any special information that you feel people should need to know.
So we'll now transition to questions, and one question that has come in already is, what is a medical home? How do I know if I have one or that it's even working as it should do? So the medical home concept is really about providing a family and child with a family-centered, accessible, continuous care provider relationship. It's been defined as the Center for All Medical Records initially, and over time there's been a policy that talks about what that comprehensive medical home is like. You can ask your doc about whether they feel that they have a medical home, or even if they understand that term. There also, medical home has transitioned to, in the broader healthcare reform world, to have steps that practices need to go through in order to achieve a patient-centered medical home status. And there's level 1, level 2, level 3. And the goal of this ultimately is to raise the quality of all practices and also incentivize quality care for physicians providing this, and also unify the understanding of what's expected for high quality care. Is that anything to add?
I think what people are confused about too is that it's the term medical home has changed over time, whereas before it was the medical home was really where your primary care physician was, and that's still to a large extent what it is, but again it's gotten a little bit broader as healthcare reform has entered the picture. Another question is, who is responsible for coordinating care across specialties? This is a hard one because, again, very often we work in what are called silos, unfortunately, where the specialty has their goals with the patient, the primary care person has their goals, and sometimes there's not good coordination or communication between all of those, or among all those people. It is our goal to try to break down those silos and make that communication seamless for patients. The goal also is that the medical home should have all of that information at their disposal, and they are the ones who are really caring for the whole patient and are asking for the subspecialist help in that care. It is also important for parents or guardians and also the young adults to have a real vested interest in making sure that everybody knows what's happening. So that communication is also important as well.
And I have just a couple comments on coordinating care across specialties. One, we do have a model of care coordination that we're teaching throughout the state of Vermont for practices that have a care coordinator. And so if a practice does have a care coordinator, they can be very helpful at knowing how to both reach a subspecialty practice, but also to help identify who's doing what part of the care coordination effort. I think one of the fears is that with all this care coordination going on, who we don't want to duplicate the roles of care coordination. So, so again, having a point person. So one thing, having my care coordinator nurse will know who the point person is at a pediatric subspecialty office that can answer questions, share information back and forth with directly. Another question has come in. Can a young adult sign a release so that a peer can support him or her in medical care? So I'll start and let Allyson finish, but I think ultimately we have to be conscious of whether that peer is in a position of power or not. So that's very sensitive issue. I think when we do, one of the tools we use is called a care conference, where we bring the patient to the table along with anyone from their healthcare team that they would like part of a conversation. It's a great time to do a care conference, would be a transition time. Maybe even both physicians can be in the same room. If not, sometimes we've done phone calls where one provider we keep all our questions for them for a 10-minute period, and they are called into that care conference. So I think if a care conference is a great place where a peer can be present, everything that's spoken and shared with the young adult is aware of, because the young adult is there as well. And then medical decision making remains with the broader team and not subjected to a powerful position that may not be best interest for that youth or child. Hope that answers.
I would just echo that. I think that's care coordinating is really a very important part of this whole process. Another question that's come in is, how do you help a young adult with social or other concerns not related strictly to health? For example, I don't have a job, how can you help me? I don't have friends, how can you help me? Again, the medical home is designed to help answer those questions, and hopefully there are people in that practice that that we can refer to help answer those, to help with giving you the resources that one needs to go forward, help with finding jobs, and help with some mental health counseling, help with social activities that can help folks in that transition process and just further in their lives in general. And hopefully that's really been started in their pediatric practice and would continue in their adult practice as well. Are there? Okay. So anyway, sorry for that. We were just checking to see if there were any other questions that came in. We really want to thank you for the questions that have come in. We also want to thank you for joining us for today's webinar. I speak for myself and Dr. Rinehart. This webinar will be archived on Vermont Family Network's website, along with many other previously recorded webinars. Be sure to visit Vermont Family Network's website at www.vermontfamilynetwork.org for a complete list of upcoming webinars, workshops, and support groups. We thank you again and wish you good transfers. Bye-bye.